My name is Jennifer White. I'm a staff psychiatrist at St. Paul's Hospital, and I have a variety of roles at St. Paul's, including working as an inpatient psychiatrist, working at the Immunodeficiency Clinic as a consultant, and with youth psychiatry through the Inner City Youth Mental Health team. My experience with male depression goes back to when I was a third-year resident, when I was participating in research. We were looking at the role of male gender socialization on help-seeking behaviors for men that were experiencing depression. There are many men who, again, with their stoicism and their persistence and the self-reliance, that wait until they're quite far gone in their depression. The severity is so severe that they're experiencing suicidal thoughts. And unfortunately, when they do wait that time to seek out help, I think that their experience with the mental health field is different than those who would seek out treatment earlier in the course. And some of the men that seek out treatment in desperation, they're being treated in more of an acute care setting or more of an emergency setting. And the reality of the situation is that emergency rooms are busy and they're crowded places. And I do worry that being treated in an acute care setting tends to perpetuate some of the stigma that they have associated with mental illness. Because we do our best in the acute care setting, but it is quite different being treated in emergency or an inpatient versus treated out in the community or an outpatient office. So some of the disadvantages of waiting and acting later on their depression is that the depression itself becomes more severe, and we may at that stage need to rely on pharmaceuticals rather than just psychotherapy to treat their illness, which unfortunately then I think perpetuates that stigma that, oh, the doctor's just handing me a pill to treat my illness. I think the other problem is that when you get to more severe forms of depression, you also get the hopelessness and the suicidal ideation. And when it becomes that severe, we need to look at safety. And sometimes we need to bring patients into hospital or even certify them. And that's taking away a right from them. It's putting them into sometimes a locked facility, which perpetuates, again, all these ideas around the stigma of depression and some of the negative implications that can come along with that. So in 2008, I collaborated with Dr. Grozniak and Dr. Mock as a resident, and we wanted to look at the impact of male socialization on men seeking help for their depression. And so what I did is I went into a local clinic, a university health clinic, and I requested from 97 men between ages 19 to 80 that they complete a series of scales for depression. And one of the scales was a typical scale for depression that picks up on the common symptoms that we tend to see more so in women than we see in men. And the second scale was the Gotland scale of male depression, which specifically picks up on some of these male-specific signs and symptoms of depression. And then the third was a masculinity scale. So they sat while they were waiting to see their family physician and completed these scales. And as you can imagine, when they're completing these scales, one would think that it would make them start to think about their emotional state or emotional concerns that they have. And then they'd go into the office for whatever reason they had come to see their family practitioner for. Following their visit, we would ask the GP whether or not they brought up any concerns around emotions, depressions, suicidal thoughts. And the interesting and alarming aspect of the study was that 4 of these 97 men had disclosed on these scales that they had suicidal ideation, yet they did not bring it up with their family physician. And those are 4 potentially high-risk cases, so 4 out of 97, which I think goes to show that we need to change how we go about asking about emotions, suicidal ideation, depression in men.